Hello and welcome. I'm Michael Pierce, and this is The Human Condition. Today we're continuing our discussion of EEG and ERP for complementary alternative and functional medicine practitioners and their patients and technicians. Now we're into Chapter 7, the EEG and ERP differences. At this point, we're here to talk about the differences of these two things. There are different applications of these. The EEG generally measures a person at rest in two states. The state 1 is the eyes closed, resting upright, and state 2 for QEEG is eyes open, resting upright in a chair. They need to be upright and awake, and we do not want them to fall asleep. When we're looking at the brain waves, we should be able to tell if they're getting drowsy, and they should be able to stay awake during the 10 minutes. We also are not doing a medical EEG. A medical EEG is different than a QEEG for holistic purposes. A medical EEG may involve hyperventilation, it may involve holding the breath, it may involve sometimes falling asleep, and it may involve an overnight sleep EEG. There's all kinds of different things that can be done, and the problem is that sometimes those tests are designed, in fact they're always designed, to show pathology. If a person does have a suspected seizure disorder and they're ordered to get have orders for an EEG, medical EEG, then they typically go to a facility that has a crash cart. And a crash cart is a set of equipment that's designed to resuscitate a person if they have a heart attack or if they stop breathing or if they have different problems. And it also has drugs in it to stop different processes that can happen to a person. And most of our offices are not designed to do that. So it's very important that a patient who needs a medical EEG goes to a neurology office with a standard medical neurology practice that has all the equipment to deal with an epileptic or seizure disorder that may happen, whether triggered or not triggered by the test. A QEEG is usually done on people that are not suspected of having a seizure disorder because we don't have the equipment for an emergency procedure like that. There are some people that have already had an EEG and they do have a particular type of seizure disorder that isn't terribly dangerous, and they choose to do a QEEG, although we don't do triggering things. We don't flash lights at them, we don't blast sound at them, we don't have strobes, we don't have them hold their breath, we don't have them hyperventilate, we don't have them fall asleep or do any of those things. We simply measure their brain waves. And in some certain cases, neurofeedback can be used to help overcome certain seizure disorders, and that is in the literature. But we have to have them pronounced healthy enough to do that first by other doctors. There are a number of people that have autoimmune types of seizure disorders, and they do well on gluten-free diets and dairy-free diets and other types of anti-inflammatory and anti-autoimmune diets, of which probably the most well-researched is the ketogenic diet, although there are others. The general idea is to reduce the burden on the immune system and to try to remove T helper 1 and T helper 2 stimulating foods, which you can obtain lists from online and in certain books, and try to bolster the T regulatory cell process so that the T regulatory cells can be more robust and they can quash or inhibit the immune reactions on either the cell-mediated or humoral-mediated side of the immune system. And so that's useful and important. Another part of the EEG and ERP is when we're using them, we're comparing them to gold standards. And there are some other gold standards in the world of brain imaging. There is SPECT brain imaging, which uses a radioactive marker that allows you to detect gamma rays, not gamma waves, but gamma rays, which are a radioactive wave that comes out of your body. And there's also the CT itself is an X-ray, which is a radioactive ionizing radiation that goes through your brain. And so all of those are different methods of measuring brain function. And these are more of a gold standard in that they can see the brain at higher resolution. There are also fMRIs that are a little bit higher resolution. And there's diffusion tensor imaging to see the white matter. So between all the different types of imaging, EEG and ERP is very useful and extremely helpful, but there are gold standards for different conditions that are kind of higher on the hierarchy of measuring certain brain conditions. Certainly an autopsy is very useful to see what goes on in the brain and understand how a brain may have had some pathology. But at autopsy, there's no electrical activity, so it's not the best way to measure a brain. It's certainly a great way to measure pathology, but it's not a great way to measure dysfunction. The methods of EEG and ERP involve sitting still and resting and having the eyes open or closed. It's very important during the eyes closed that the patient be able to have their eyes relax and aim straight ahead. We don't want the patient looking around in their own visual field. Often patients have sleep deprivation or other types of sleep disorders that may make them look around under their eyelids, and they don't feel this process of slow rolling eye movements. Sometimes children are bored and they'll look around under their eyelids, not because they're seeing anything, they're just bored. When the eyes are open, it's very important to instruct the patient to stare straight ahead and look at a target. I like to have my patients look at a target below their visual horizon, because the more surface area of the eyes are covered by your eyelids, the less dry they can get. So we want to make sure that they're doing that correctly. When they're listening to an oddball paradigm for an ERP, we want them again to have their eyes closed, staring straight ahead, not moving. We want them to listen to the sound, and we want them to click the mouse. We don't want them to have sync blinks where they blink their eyes when they click the mouse. We don't want them to move their body and be too aggressive. Sometimes with young people, they realize it's a game and they get very hyperactive, and they throw their whole body into clicking the mouse, and they go, and you don't want to do that. You want to tell them to be very calm and just click the mouse. Just click the mouse as relaxed as you can. Don't use any other muscles. Just click the mouse as fast as you can, but gently. And sometimes when you tell a child to click a mouse as fast as they can, they throw their whole body into it, and they listen and listen, and then they use their whole body. We don't want to recruit all of that activity. It's going to screw up our quality of our readings. So for the oddball paradigm with the eyes open, the same idea is they want to stare at the screen. There will be blinks, that's normal. And they will look at the screen, and then they'll blink when they see the indication of what is instructed for them, of the oddball arrow pointing in the wrong direction. And each system will have different rules and show you how to do that. And I also like to explain to people that when we're done, at some point, they're probably going to have neurofeedback. A lot of them will qualify for neurofeedback. And we like to explain that neurofeedback, there are simple and complex ones, and there's nothing wrong with the simple ones. There are some very simple two-channel neurofeedback where they put 2 electrodes on a person's head and do some very simple retraining of the brain. And those methods are tried and true, and they can work very, very well. Just because some offices use more complex neurofeedback or they use more complex equipment or software, doesn't mean that everybody needs that. In fact, more often, most people don't need that complex type of work, but I end up doing a lot of complex type of work, and S-Loretta neurofeedback or infraslow fluctuation neurofeedback and other types of multivariate coherence or directional coherence. These are things that are not necessary for everybody and can be overkill. So we want to tell people that, just because we may use very complex neurofeedback, we're not saying that simple neurofeedback is bad or wasteful or ineffective. It's often very, very good and very useful and very affordable. In many cases, it's easier to do a home training system with your therapist, and we encourage people to, especially in the environment of COVID-19, to lease machines from their practitioner and use these methods at home. In some cases, they can do it unsupervised, and in some cases, they can do it supervised with the clinician online running the session for them. It all depends on what level of function they have. If they have a very clear medical diagnosis, then they're going to have every session run by the therapist. If they have an optimal performance desire and there's nothing wrong with them as far as a diagnosis goes, and they're simply doing peak performance, they may very well be instructed to do sessions at home unsupervised, and then perhaps once a week or once a month or once every 2 weeks, the clinician might review the file with them and ask them how they're doing, and look at the data that was recorded and see how the sessions went. And so in that way, there are all kinds of choices now that have expanded since COVID-19 that actually allow people to do these trainings at home on varying levels. The devices that are less expensive are certainly easier and less expensive for a family to take home. And it's very useful for a family to consider if they've got 3 or 4 family members that want to do neurofeedback. They might want to lease a machine for home use. And then they can have the clinician log in and do kind of a telemedicine visit where the clinician is running the machine using something like TeamViewer or some other control mechanism where they control the computer and operate the session, and they can see the patient on the camera, and they can see all the hookups, and the family can be taught how to put the electrodes on their head. And with today's systems, we can, as clinicians, see if there's a good electrical connection, and we can verify and make sure that the patient or their family was able to connect the electrodes or the cap to their head accurately. And that works very well, and it can be done correctly and with great precision. So that's Chapter 7. Thank you.